Well, I'd first like to start by saying thank you to Congressman Hoyer, because he is doing great work for the epilepsy cause, being our representative in Washington. And I think it's, you know, the work that we do really does require what he does. Secondly, I'd like to say it's really an honor for me to be here speaking in this symposium in memory of Judith Hoyer. She was really an advocate for epilepsy, and you know, many of us are in the day-to-day work that we do, seeing people with epilepsy, doing research on epilepsy, but it really does require everybody at all levels to really support the work that we do. Well, I wanted to talk today about seizure forecasting. This is an area of great interest to me, and I just want to say that I'm going to be talking about the work of lots of different people here, some who have collaborated directly with me and some who haven't. And if you've done some work in seizure forecasting, I haven't mentioned your name, it doesn't mean that it's not important. So these are my disclosures. Why should we think about seizure forecasting? If you ask people with epilepsy, they will say that the sudden and apparently unpredictable nature of seizures is one of the most disabling aspects of having the disorder. In addition, as Congressman Hoyer just said, it's possible, we don't know how to stop SUDEP. Predicting when seizures might happen could be one of the angles, one of the avenues that we use when we're trying to prevent SUDEP in our patients. So if somebody could tell when they were going to have a seizure, not necessarily that they know the exact moment, but if you had a time when you would say, like, as in the word forecasting, like a weather forecast, that tomorrow will be a dangerous day. There's a 50% chance that you might have a seizure on the subsequent 24 hours. It could change, if you're somebody with epilepsy, it could change what you do. You might change your hazardous activities. Again, supervision to reduce the SUDEP risk. We know that direct supervision is one of the things that's been demonstrated to help prevent SUDEP. It might affect your overall work performance and also social activities. I have one patient who says, if I knew when I was going to have a seizure, I would never get on the phone with my ex-wife. Also, we could think that we might be able to intervene during a high-risk period. You know, should you alter anti-epileptic drug regimens during a high-risk period? You know, we've done that in some cases where sometimes we've tried to alter in women who have seizures around the time of their menstrual cycle to change anti-epileptic drugs around that time. It's been modestly successful. Other people who have seizures just at night may take increased frequency or increased amounts of their anti-epileptic drugs before they go to sleep. Or we might want to initiate stress reduction. As I'll explain in a few minutes, one of the things that people talk about, people with epilepsy as a seizure trigger, is stress. And we, Dr. Sheryl Haut and I, completed a study demonstrating that stress reduction can, in fact, reduce seizures. So when we think about seizure prediction, I think about three different time courses. A long-term time course where we're talking about, will a seizure happen in the coming months or years? A medium term, which is probably, in my view, the one that we may be the closest to be able to do accurately in the next 24 to 48 hours. And then short term, just in minutes. So I'm going to briefly talk about long term, but really the focus of this talk is the medium term and the short term. So for example, we think about recurrence of new onset seizures. We know what the risk factors might be, like a prior brain insult, an EEG abnormality, or an abnormal MRI. And recurrence after a long seizure-free interval is really based on many factors. And there was a very nice article by Lamberink in Lancet where they developed an excellent algorithm that can be done online to estimate recurrence risk after medication withdrawal, because that's one that's a common clinical problem. We see somebody who's been seizure-free for 7 or 8 years, they're on a single anti-epileptic drug, and you have to go through that decision about how safe is it to stop your medication. But I'm going to concentrate, like I said, a little bit more on the next 24 to 48 hours type of prediction. This is a graph that I've used, and there we go. Let's see where, okay, there's my arrow. So what I think about is this being the seizure threshold and this being the seizure tendency. So when the seizure tendency exceeds seizure threshold, that's when the seizure comes on. One of the big problems in studying triggers or studying or being able to predict when seizures happen is you can have substantial changes in this seizure tendency but not have a seizure. So for example, in this case, this may be a single patient and he drinks a six-pack of beer and doesn't have a seizure. A week later, he comes into my office and says, Dr. Privitera, you told me that alcohol would make my seizures happen, but I drank a six-pack and I even had a couple of shots that night at a party and I didn't have a seizure, so maybe you don't know what you're talking about. And then I go on the wall or I get a piece of paper and I draw this graph. I said, see, this is what happened. Your seizure tendency went up, but it didn't reach this threshold. But there may be, as you can imagine, multiple factors. There's probably reasons that this seizure threshold varies from day to day that we're not aware of. But maybe stress, alcohol, missed medications, all these things can affect that seizure threshold, and they may be additive. And it may be when those things all hit at once that a seizure happens. But again, our understanding of when seizures happen is very complicated because there's lots of changes that occur beneath this line that we may or may not be aware of. And as I'll talk to you in a few minutes, understanding and studying people who have chronic indwelling electrodes may help us with this because we can look at EEG changes that go on long term that may also help predict when these seizures might happen. So if you listen to the patient, patients will say, I can tell you when I'm going to have a seizure. And most of us as clinicians will say, well, maybe you have some inkling, but I don't think you're really able to predict it. But there have been some very interesting studies, and many of these were started by Sheryl Haut. Some other people have contributed, and we did a recent study that was published in Neurology about seizure forecasting. So people identify triggers, and if you ask patients with epilepsy, the #1 trigger that's reported pretty consistently is stress, high stress. And as I'll talk to you about in a minute, it's kind of difficult to exactly map in an individual person what they really mean by stress. But prodromes can happen, and there can be mood or premonitory symptoms that are a little bit different than auras. So when we think about auras, we think about what's happening right before the seizure, in that 30 seconds or a minute right before the seizure. But prodromes are something that we think about in a longer time course, so that this may happen in the day or 2 days before, and in fact, I think mostly parents and family members will say, often in retrospect, I knew a seizure was coming. Something was different about them, and a seizure was ready to happen. One of the, I think, important features of looking at seizure prediction is not just looking at it retrospectively and saying, because every patient will say, I knew a seizure was coming. So one of the important things in looking at this in a diary is to ask patients prospectively. So what we, as I'll demonstrate what we did in our study, is we asked patients every 24 or every 12 hours, what do you think the probability of having a seizure is in the next 24 hours? Is it low or high? And in that way, you can look at their predictive ability, their false positive and false negative, and I think that that's really important. It's important not to just look at retrospective assessment. As one of my patients used to say, I had a seizure last weekend because I always have a seizure when my mother-in-law is in town. So here's kind of a visual outline of what we're going to try to talk about today. I'm going to try to talk about all these different factors and how they can add into accurate seizure prediction, self-prediction, cardiac things including pulse and heart rate variability, stress, other triggers, looking at electrodermal activity, circadian findings that have some recent studies that have been very interesting, and also with EEG. So again, when we think about this, as I mentioned before, 90% of people with epilepsy identify at least one precipitant, and the most common one that they talk about is stress. People in the stress area define stress, at least in general, as a real or perceived threat to health and or well-being. So that's kind of a definition that we can use. But if you look at a number of different surveys, people with epilepsy report stress as a big one. We did a survey of patients in our clinic and asked them, what do you think what do you think are your triggers? If you have a trigger, what is it? And if you think stress is a trigger, have you ever used stress reduction? And we were pretty surprised because a lot of people, without telling any of us, had been using some sort of stress reduction. It might have been exercise, yoga, or a specific stress reduction program. But if you ask those people, 88% of them said they thought it helped their seizures. The only difference that we found when we surveyed people who thought their seizures were triggered by stress versus those who didn't think seizures were triggered by stress was underlying anxiety. So people who thought their seizures were triggered by stress had significantly higher scores on the generalized anxiety disorder, the so-called GAD-7, which is a very easy thing. We use it every day, every visit in our patients in our clinic, both the NITI to screen for depression and we use the GAD to screen for anxiety. I personally think, and I think many people would agree with me, that anxiety is one of the most underdiagnosed comorbidities in epilepsy, and if we identify it more, maybe we will be able to help people with who seem to have more anxiety-triggered seizures. Sheryl Haut published back in 2007 what I think is a very important study looking at patient self-prediction. So again, what she followed 74 people with epilepsy. They filled out a diary every day, and she asked them, what's the chance you will have a seizure in the next 24 hours? There were 15,000 diary days, 1,400 seizure days, and seizure predictors. So what she found was that there's a subset of people, about 1 out of 5, who she called seizure predictors. These people were significantly better than chance at predicting when their seizure would happen. They weren't perfect, but many of these people were able to determine in a very important way what would happen in the next 24 hours. So when you looked at the predictors, if you took patient self-prediction and then you added patient self-reported stress, that was the combination that seemed to lead to the best prediction. This is a graphic demonstration of the accuracy of prediction, whether a seizure actually happened or didn't. So if a patient said a seizure was extremely likely, you can see in these purple ones that a seizure occurred in somewhere around 37 to 38%. In the group, if a patient, in this high prediction group, if a patient said a seizure was extremely unlikely, then it was about a 10% chance. So again, it wasn't 100 and 0. It wasn't, but this was a pretty substantial difference between somebody who thought they were at one end of the likelihood versus the other end of the likelihood in terms of seizure prediction. Subsequent to that, and again, with data, looking at the data and the surveys about stress reduction, we started an intervention study that looked at both seizure prediction and stress reduction. So it was called the SMILE study for stress management intervention for living with epilepsy. It's always good to have a smart graduate student who can do those little acronyms for you. So this was a prospective, randomized controlled trial. Patients were randomly assigned a stress reduction intervention versus a sham intervention, and at the same time, we did seizure prediction. So patients had a smartphone. It was a specific for the study. They entered twice daily diary entries over 5 months, and each day they looked at stress levels and a variety of other mood and stress-related variables, and we did seizure prediction. And the seizure prediction, as in Dr. Haut's earlier studies, was a 5-level seizure prediction. So it was either extremely unlikely, unlikely, neutral, very likely, or extremely likely. And then the mood stress variables, as I'll show you on the next slide, were ranked in a visual analog scale from 0 to 100. So this is what the phones look like. And there was this little visual analog, and you can see on this one where it says unpleasant or pleasant, the patient puts their finger on the bar and they move the bar back and forth and a little number comes up. So if you move your finger this way, it gets closer to 100, and if you move it that way, it goes down to 0. This was very important because we wanted to try to reduce the burden on the individual patients of doing this diary every day. And as I'll show you in a few minutes, patients were actually very eager to do it and were highly compliant. But these visual analog scales would pop up quickly, and the patients were able to do them very quickly. Here's another one. Which of these best describes how you feel right now, relaxed or stressed? And if you put your finger over here, you would get an 80. And this one, how worried do you feel right now? Not at all worried or extremely worried. Again, using your finger on the visual analog scale allowed patients to respond quickly. So here's the overall diagram of the study. Patients entered with at least 2 or more seizures per month. They had to tell us that there was some kind of a trigger. It didn't have to be stress. It could be some other trigger. And their medications were all held stable. They had a 2-month baseline period where they kept track of seizures, they kept track of stress levels, and they did the full diary twice a day. And then at the end of the 2-month observation, they went into a 3-month treatment period where they got twice daily active intervention, and this was a stress reduction intervention, something called progressive muscle relaxation. We chose progressive muscle relaxation because it was simple to do, easily repeatable. We had a trainer go through, and then in the phone itself, if they had difficulty doing the stress reduction, they could plug a set of headphones in, and it would take them through that same stress reduction. In the sham control, because we really wanted to try to match it in a double-blind way, patients twice daily kept track of their seizures, kept track of all their stress levels, just like the other group, but instead of getting a stress reduction intervention, they just wrote down the activities of the day. This is very important because I think we really sort of, I don't want to say overdid it, but in retrospect, I think I probably overdid it trying to make my control so closely matched, and I'll explain why in a second. So we had 64 subjects who completed the whole 5-month study, and I think this was really important, that 94% of the days all the diary entries were completed. So the patients who were involved in this study were very interested in doing it. They were willing to do a diary like this twice a day. Our active treatment group reduced the median seizure frequency by 29%, which was 0.5, p less than 0.5 compared to baseline. But the sham group actually reduced by 25% as well. Part of that is probably placebo, but I think part of it was the fact that these people probably got some mindfulness effect out of doing the diary and keeping track. And in fact, some of the people after the study said to me, oh yeah, writing down what happened during the day was really sort of helpful for me to think about what my seizure triggers might have been. So we think that there was more than just a placebo effect, that it really was some kind of a mindfulness effect in the sham group. Nevertheless, I think both arms actually improved. The other thing, though, that sort of goes against our stress hypothesis is that the active treatment group did report a statistically significant drop in stress, self-reported stress, compared to the sham group, but this was not correlated with seizure reduction. So the people who had the biggest drop in stress did not necessarily have the biggest drop in seizures. So it doesn't disprove the hypothesis, but it does tell us that there's more going on with stress as a seizure trigger than just patients' self-report of stress. And we also looked at anxiety levels because of that previous survey that we did in the clinic about anxiety levels, and that the changes in anxiety level did not correlate with seizure improvement either. The other part of the study was the seizure precipitation or the seizure prediction. And again, we showed very similar findings to what Dr. Haut did years ago. We had a subgroup of the highest predictors out of the 64 of 10. That group actually had an odds ratio of 8.36. So that when they said a seizure was extremely likely, they were 8.36 times more likely to have a seizure than when they said a seizure was extremely unlikely. Many people also predicted, well, their prediction might have been tied to seizure clusters. So they probably used clustering to help predict their seizures. So it did seem, when you looked at the raw data, it did seem like many of the people increased their seizure probability within the first 2 days after having a seizure. If somebody scored high in sad, nervous, worried, or tense, or stressed, that combination, that significantly increased the likelihood that somebody would predict a seizure was coming, but it wasn't actually very accurate for actual seizures. So again, looking at it really precisely, what patients had told us and what we translated what patients had told us into the diaries was not exactly what was there. So the conclusion out of this part is that some people are better predictors, but really the basis of that prediction remains to be seen. We really don't understand how people can predict their seizures. And again, as I move now into the next part of the talk about intracranial EEG and other ways to predict, one of my hypotheses is that some of these people may actually be responding to subclinical EEG changes, and we'll be able to test that when we start looking at chronic intracranial recordings. But again, this just compares the results in our study of the SMILE study versus the Dr. Haut study. And what you can see in addition is that when they said the seizures were very unlikely, these are the odds ratios, you can see the odds ratios marching up as quite unlikely, fairly likely, very likely, almost certain in both of the different studies. So we now have, as part of these two studies, 4,500 seizures and 26,000 diary entries. So I think, at least in my mind, there is no doubt that there's some information in patient self-report that can help us in understanding how to predict and when to predict seizures. Many of you are aware of the new VNS system that also ties itself to heart rate changes. What's been demonstrated is that just prior to seizures or at the beginning of seizures, there's a significant increase in heart rate. So VNS, because they were able to create a device that simultaneously measured heart rate, were able to put an automatic trigger into the vagus nerve stimulator that responded to changes in heart rate. So it's not just simply an increase in heart rate, because you can exercise and have an increase in heart rate, but they looked very carefully, the people who designed this one, very carefully at the rate of change of heart rate to be able to reduce the false positive seizure triggers with exercise or other ways that your heart rate goes up, and really tied it to the kinds of heart rate changes that happen with seizures. This is an acute change, so these are like immediate changes that occur right at the beginning of seizures. But there's also a significant group of people that are looking at heart rate variability and other changes that may occur well before seizures, and those with some of the wearables, as I'll talk about in a few minutes, may be additional factors that we can look at in terms of seizure prediction. EEG is something that people have looked at for many years to try to look at seizure prediction, and I'll just kind of walk through that a little bit. So my conclusion is it's really still evolving. There have been dozens of studies over the years looking at linear and nonlinear time series analysis methods aiming to predict seizures, usually from scalp EEG. And there were a number of positive reports early on, and we're talking even into the 1990s and early 2000s, but many of them were not reproducible. And Dr. Hughes went in 2008, and he looked at kind of an early meta-analysis before we called them meta-analyses. And he looked at 47 different reports, and his conclusion was that limited progress has been made in predicting a seizure from interictal EEG, but I think the news now is that long-term intracranial recordings are giving us much different information, and I think very important information, as I'll demonstrate. This was a very early study by Jean Gottman that looked at interictal spiking in patients with intracranial electrodes, bilateral depth electrodes, looking at spike frequency and seizures. This is published in 1985. Probably only a few people were around in 1985 reading those journals, right? I was still a fellow. So what Dr. Gottman did was, this is the solid lines are the interictal spike frequency, and the arrows are the seizures themselves. So the idea was, oh, maybe interictal spike frequency is going to increase prior to seizures. But what he found instead was that the seizures happen here, and then the interictal spike frequency pops up. It drops back down, maybe starts drifting up a little bit, and this is what some of the newer long-term intracranial data would suggest. Maybe there's a trend going up here, but it's really the seizures that trigger the big push up in the interictal spikes. So his conclusion from this study was that increases in interictal spike frequency were more tied to the prior seizure than they were to a change in interictal spike frequency preceding a seizure. That was 1985. The chronic intracranial recordings that we get from systems like the responsive neurostimulator have allowed people to look more long-term at these kinds of changes. So there's a number of different things. So number one, a lot of the prior studies were done in epilepsy monitoring units where we have people with electrodes in, they just came out of the operating room, we're taking their medications away, we're sleep depriving them. So looking at seizure recurrence and seizure prediction in that model is really not exactly what we're looking at when we're talking to somebody in the clinic. The RNS probably brings us a little bit closer to that. So the RNS, we have implanted strips or depth electrodes. It detects interictal spikes or what are called seizure-like bursts from the intracranial EEG, and then provides an electrical stimulation that stops the seizures. An important feature when you look at these recordings is that there are a lot more electrographic seizures than clinical seizures that trigger these stimulations. So if you look at somebody with a typical RNS, they may have 100 stimulations in a day and no clinical seizures. So there's lots and lots of subclinical electrographic bursts, and not just spikes, but things that look like short electrographic seizures or bursts that occur throughout the day. I think one of the most important recent studies was this study of long-term monitoring by Dean Freestone and his group at Melbourne. They specifically designed a system that implanted electrodes intracranially, so you had chronic recording electrodes, that was hooked then to a device, a detection device, fed into an algorithm, and then it would give the patient indication about whether a seizure was likely or unlikely based on the EEG recordings. The EEG, the algorithm learned from the patient as it recorded more and more over time, and then they actually had this handheld device that in their study had a green light, a yellow light, and a red light, with the green light saying probability is low, yellow light saying probability is slightly higher, red light saying probability is the highest. In that study that they published, the patients were recorded between 6 months and 3 years. There was a statistically significant ability to predict when seizures were happening. It was a tough study. You had to take people chronically recording over time, but it did sort of prove the hypothesis that there is information in long-term intracranial recordings in many of these people that will help allow us to do a better prediction than what we're able to do right now, which is essentially not much. So Dean published a summary paper putting together all their sort of lessons from their intracranial monitoring study. And I think these are really important for us as we move ahead in this seizure prediction area. So number one was pooling data across patients may not be an effective strategy. And that's because different patients have different patterns. We know, for example, frontal lobe patients cluster at night, whereas temporal lobe patients typically cluster in the late morning or early morning and later in the afternoon. As I mentioned, data that are recorded in the epilepsy monitoring unit are not always representative of normal seizures. So you're not really looking at seizures that happen exactly like they would if you weren't in that area. This is an important one. False positives, as he says, in the deterministic sense, may not represent false positives in the probabilistic sense. So that is, when the seizure prediction program, whether it's the diary or the intracranial EEG or anything else, says threshold changed, but you didn't have a seizure, it doesn't mean that your prediction system was wrong. Again, going back here, if the seizure tendency is going up like that, and your system says, oh, seizure tendency went up, but all you're measuring is actual seizures, it may not be, it looks like it's a false positive prediction of seizure, but in fact, what it is a true positive prediction of the seizure tendency changing, but not necessarily reaching seizure threshold. What's very clear is that multivariate models are needed. We have lots of different ways that we can look at seizure prediction, and most likely the most accurate seizure prediction programs will incorporate multiple different areas. And the relationship of epileptic EEG biomarkers and seizures is patient-specific. Seizures cluster and cycle. So clustering and cycling of seizures, as I'll point out in the next few studies, is also extremely important and may help us, again, putting it all into an algorithm to get where we want to be. And then the other complicating factor is that individual patients may have more than one seizure type. And if they have more than one seizure type, especially if they're coming from different parts of the brain, those seizures may have different onset mechanisms. So just looking at every single seizure in somebody who really has two separate foci may not give us the best prediction ideas. I'm going to talk now about some very interesting, very recent data that was published about circadian changes. So we've known about circadian changes in terms of temporal and neocortical seizures for quite some time. So if you look at people with medial temporal lobe epilepsy, their seizures tend to come between 7 and 10 a.m. or late afternoon, 4 to 7 p.m. Now that's group. I mean, obviously individual patients may be individual, but when you look at the seizure patterns, this is clearly a pattern. Whereas frontal lobe or neocortical seizures peak at 4 to 7 a.m. I think for those of us that do work in epilepsy monitoring units or see a lot of people with frontal lobe epilepsy, you know that many of these people with frontal lobe epilepsy will have tons of seizures at night and very rarely have some of those seizures during the day. And so there's quite a number of studies, including the Herman study from 2001, Caroli, who's a part of Dean Freestone's group, but that's the Neurovista study, and then another study where David Spencer looked at these kinds of patterns with the responsive neurostimulator. So these are pretty well-established patterns that we've seen. Here's some actual examples. You can see, for example, this patient, if this is the time of the day when the seizures occurred, it's not just equally spaced. There's a cluster here, down a little bit more in the middle of the day, and increased here. Now, some of these patients have more equal seizure frequencies. Other people have clear clusters of seizures. And again, here's a big cluster for this patient. This one has that more bimodal distribution of the seizure clustering. So again, people are different, and the algorithm that you use to predict a seizure in an individual patient will have to take these kinds of clustering patterns into account. Max Baud and Vikram Rao published a very interesting paper in Nature Communications recently. They looked at long-term assessment of interictal epileptiform activity and seizures in patients who had responsive neurostimulators. Some of these patients had RNS up to 10 years. So this is where it becomes very helpful to have those extremely long-term recordings. What they found was that interictal spikes and rhythmic discharges oscillate with circadian and multi-day periods that differ from person to person. So the circadian ones we've sort of known about, the individual 24-hour ones. What they found, which was quite interesting, were that there were multi-day periodicities, most commonly in the 20 to 30-day duration, that were relatively stable over periods of time that lasted up to years, and they occurred in both men and women. So most of us know that, in women of childbearing age who are having menstrual cycles, we know that seizures may cluster in those kinds of cycles, but similar cycles between 20 and 30 days were also seen in men. Their finding that was also important in terms of seizure prediction was that seizures occur preferentially during the rising phase of these multi-day interictal rhythms. This was, I think, information that it tells us we're just at the start. There are patterns underlying seizure frequency that we can look at that we're only beginning to be able to look at because of these chronic recordings that I think will move us quite far ahead in the next 5 to 10 years with seizure prediction. So here's some of the graphs from their study. If you look down here, this is the long-term stretch of 1 year. And this is the hourly counts, and you can see that the counts of the interictal spikes go up, and then the seizures are these red dots. If you can see them down here, it's probably a little bit easier to see here. So there are patterns of increasing interictal spikes and these short bursts recorded by the RNS with the seizures as the red dots. So this little stretch here, that's a 2-month stretch, is stretched out here, and you can see that there's also multiple fluctuations that go on, even beyond like day-to-day fluctuations that go on with interictal spiking. But if you look multi-day, you can see these patterns that you wouldn't ordinarily be able to detect if you were just looking at somebody's EEG without stretching it out like this. Finally, a couple of comments about stress and stress hormones. So there's rodent data indicating the interaction of the hypothalamic pituitary axis and seizures, because we've been thinking, how can we better measure the influence of stress? We can look at, as we did in our previous study, patient self-reports of stress, but that's kind of messy. I think it's important to put it in there when we do a multivariate mix and when we do the machine learning techniques to really try to put all these pieces together. But we may want to look for more biomarkers of stress. So we know that stress activates the hypothalamic pituitary axis, producing glucocorticoid secretion. At least in rodent studies, we know that systemic administration of glucocorticoids can increase neuronal excitability and seizure frequency. And then at least in one study in animals, corticotropin-releasing hormone antagonists blocked seizure activation in a pilocarpine model. A researcher in our site at University of Cincinnati also has some interesting wearable devices. So we know about, everybody has their little wrist device that tells you your pulse and how many steps you took, and you're going to be really happy because the convention center is really far from the hotel with your step counts here. But Jason Heikenfeld has developed, at our place, through work with the Department of Defense, this sensor. So it sticks to the wrist almost like a Band-Aid, but it has a microprocessor in it. And what he does is he can actually measure sweat content, and then it transmits via Bluetooth to a receiver. The original design was really looking at sodium and potassium and sweat. And one of the things he was doing was working for the Department of Defense to be able to check on, for example, soldiers out in the desert to see who's most close to being dehydrated, who has evidence that they're really not going to be doing well, and call those people in. So we've been working with him now because, as Jason said to me, oh, cortisol, no problem, we can do it. But but that was a while ago, and it's a little bit harder than, than Jason had the idea, but we still do think we can do a cortisol measure like this. So this is one of the things that we think would be a biomarker for stress, is to look at over day-to-day cortisol measures using something like this, where you can get almost continuous cortisol measures in patients with epilepsy, look at their baseline, and then see how that correlates with their reports of stress, and again, in a seizure prediction paradigm. I also want to thank the Epilepsy Foundation, because the Epilepsy Foundation started getting people together for this seizure gauge challenge. I mean, their reasoning was patients, other than obviously developing a new drug or a new treatment that would stop seizures, the foundation did a survey and said to patients, what would really help you? And patients very frequently said, tell me when my seizure is going to happen. If I only have one seizure a month, I could live so differently if I knew when that seizure was going to happen. Again, going back to the beginning of where I started with this. So the Epilepsy Foundation put out a call for proposals to look at developing this type of seizure gauge. So they said, we want to use patients with intracranial EEG, like the RNS, combine it with other modalities like the e-diary, pulse, and electrodermal, use the findings to create non-invasive forecasting solutions, and then use advanced statistics and machine learning to create models. So a number of us got together in these workshops. Several people put their proposals in, and one proposal was funded. But I think many of us will be doing additional studies in this area. But I really do want to thank the Epilepsy Foundation for raising awareness about the need for seizure forecasting and the seizure gauge. So I'm going to finish up now by just concluding that, number one, seizure forecasting is possible. We can do it now. We can probably do it better than chance in many patients. I don't want to say most patients, but many patients. It's going to be multimodal. There's no one single methodology that really helps us do it. Like some patients may be better self-predictors. Other people, maybe it looks like we need other biomarkers. But it is important because changes in seizure likelihood could lead to pharmacologic, device, or behavioral interventions that may help prevent seizures. And then finally, as I mentioned right at the beginning, SUDEP happens. The one thing we know is that when people are supervised, SUDEP is actually less likely. Being able to predict when a seizure happens might be the one thing that we can do until we understand more about the basic mechanisms and the underlying problems with SUDEP, is improving our ability to predict seizures. That may be one way that we can really intervene and potentially help our patients avoid that most horrible of outcomes from epilepsy. So I want to thank collaborators, Sheryl Haut at Albert Einstein and Montefiore, several people who did the animal studies, a number of people who collaborated with us on the SMILE study, and then the stress analysis from our surveys, and then our funding for the study was from the Shore Foundation and also from the Epilepsy Foundation. And thank you very much for your attention.